Good morning. My name's Dr Farrant. Can I just confirm your name, please?
Ben Smith.
I'm just going to examine your heart today. I'll have a look at you from the end of the bed first. Take a deep breath in for me, please. And out. Can I have a look at your hands, please? And turn them over for me. Okay, I'm just going to have a look at your finger. I'm just going to feel the pulses in your wrist. And relax that arm. Do you have any pain in your shoulder?
No.
Okay. Just let me take the weight of your arm. And relax. Just rest your head back for me, please. I'm just going to feel the pulse in your neck. Okay. And if you just turn your head to look that way for me. Do you have any pain in your abdomen?
No.
I'm just going to press on it. If you just look forward for me, please. Could you just pull down on your eyelids for me, please? And relax. Could you open your mouth for me, please? And stick your tongue out, please. That's great, and relax, thank you. I'm just going to have a look at your chest. I'm now going to have a feel of your chest. Okay. I'm now going to have a listen. Could I get you to roll onto that side for me, please? Perfect. And relax. Just going to have another feel of your chest. Okay. I'm now going to have a listen. Okay, and if you just go back to onto your back for me, please. Could you now sit forward, please? Okay, I'm just going to have a listen to your neck. Deep breath in and hold your breath. And breathe away. Deep breath in, hold your breath, and breathe away. I'm just going to have a look at your back now. Could you take a deep breath in for me, please? And out. around again. And out. I'm just going to press on the bottom of your back. And just lie back for me. Just going to have a look at your legs. Thank you. So to complete my examination, I would like to take a history, check the patient's blood pressure, check for radiofemoral delay, and perform an ECG.
Would you like to present your findings with this gentleman?
So I believe that this gentleman had a normal cardiovascular examination. There were no positive cardiac findings that I was able to elicit. The only examination finding that I was able to see was a scar on the upper part of the right side of his abdomen, though this was not in keeping with a surgical scar, so I do not think that it's relevant to this examination today.
During your examination, you rolled the patient onto their left and you re-auscultated at the apex. Can you explain why you did this?
I rolled the patient onto their left side to attempt to listen to the murmur of mitral stenosis, which is a mid-diastolic murmur, which is often difficult to auscultate. I also used the bell of the stethoscope as well as the diaphragm, which is useful at listening for low frequency murmurs.
Can you explain the relevance of sitting the patient forward?
So when sitting a patient forward, it helps to bring the heart closer to the front of the chest, which helps to aid with auscultating for the murmur of aortic regurgitation, which is best heard in expiration at the lower left sternal edge.
If this young patient presents with shortness of breath on exertion, can you tell me how you would investigate him further?
So the first thing I would do would be to take a detailed history, assessing the extent of the exertional breathlessness, checking for any chest pain, also investigating for signs of syncope or pre-syncope. I would take a detailed family history, and then following this, I would perform an ECG and an echocardiogram, and depending on those findings, I might consider performing a 24-hour heart monitor or a cardiac MRI scan.
If these investigations are suggestive of a hypertrophic cardiomyopathy, for instance, what clinical signs may be present in that situation?
So it may be that a patient with hypertrophic cardiomyopathy has no positive clinical signs on examination, but there are two signs which you can sometimes see. The first would be an ejection systolic murmur caused by left ventricular outflow tract obstruction, and the second would be a pansystolic murmur, which is caused by systolic anterior motion of the mitral valve, which results in mitral regurgitation.
What are the causes of cardiac hypertrophy?
So cardiac hypertrophy can be caused by pressure overload in conditions such as hypertension, aortic stenosis, or people with a subaortic membrane. It can be caused by hypertrophic cardiomyopathy, which is a genetic condition. And then there are other causes of cardiac hypertrophy, such as Fabry's disease, amyloidosis, or mitochondrial disease.
How would you treat hypertrophic cardiomyopathy?
So I would first of all think about treating patients' symptoms with beta blockers, and then second line with either disopyramide or a myosin inhibitor such as mavacamten. I would assess a patient for their risk of sudden cardiac death and consider implanting a defibrillator or ICD. I would assess patients' genetics to aid with familial evaluation. And in certain cases of severe disease, patients can be referred for septal reduction therapy, which can be in the form of either a myomectomy or alcohol septal ablation.
Thank you.
Thank you.
The majority of patients for the PACES examination will obviously have some clinical signs, but occasionally, as in this case, the examination can be normal. You must be aware of this and prepare for this eventuality. This can often throw candidates if they are not aware of this eventuality and can lead to candidates making up clinical signs in a desperate attempt to find an abnormality. In this situation, you must have confidence in your own ability, and if you truly believe there are no obvious clinical abnormal signs, you should be forthright enough to say so. There are various ways of presenting a normal examination. You could simply say, "My cardiovascular examination is normal," or you could be a bit more expansive and say, "The patient was comfortable at rest, pulse 70 beats per minute normal, there were no obvious cardiac murmurs or abnormal clinical signs." It is perfectly okay and probably more professional, however, to keep your presentation to the point. A lot of candidates feel they must take up a lot of time presenting their findings in the hope that this will give them less time to be asked questions by the examiner. This can, however, lead to the presentation sounding more like a medical student rather than an MRCP candidate, and can often give the examiner a feeling that the candidate is over-presenting irrelevant negative findings. I would therefore suggest you try and be as succinct as possible. There are many marks given for a slick, systematic clinical examination and how you interact with the patient. Clear instructions should be given to the patient to follow, and you should ensure you maintain patient comfort at all times. If the clinical examination is normal, then the examiner's questions may be more general, and as in this case, perhaps involve how to investigate a patient presenting with breathlessness.